Welcome everyone to today's webinar, Insights and Innovation from the Evolving Role of the CFO. I am Molly Gamble with Becker's Hospital Review. On behalf of Becker's Healthcare, welcome and thank you so much for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. First, we will begin today's webinar with a presentation and then have time at the end of the hour for a question and answer session. If you have any questions throughout today's webinar, you can type those into the Q&A box you see on your screen. Today's session is being recorded and will be made available after the event. You can use the same link to log in that you used to log into today's webinar to access that recording. And finally, if at any time you have trouble with audio or video, please try refreshing your browser. You can also submit any technical questions into that Q&A box. We are here to help. So let's get started with our program. Surgical advancements are changing the healthcare landscape, and hospitals and health systems need to keep up to drive revenue and attract physicians, staff, and patients. Today, we are joined by three CFOs who will share how they are using quality data to help develop and sustain financially viable robotic surgery service lines in their markets. Jerry, Vin, and Scott, thank you so much for joining us today. I'm going to turn it over to each of you to share a bit more about yourselves and your institutions. Jerry, let me turn to you first.
Thank you. Good morning, everyone. My name is Jerry Yang, and I am the operations CFO for Multicare Health Systems based out of Tacoma, Washington. We have about 11 hospitals where we run about $4.3 billion in annual net revenue. Outside of our hospitals, we do operate several major physician practice clinics, urgent cares, off-site emergency centers, and the whole continuum. Fairly major organization here in Washington, and we're very community-based and very, very happy to be here. Thank you.
Jerry. Vin, can we turn to you next?
Sure. Hi, Vin McDermott, Newton-Wellesley Hospital in Boston, part of the Mass General Brigham system. Mass General Brigham is the largest employer in New England with 85,000 employees, multiple hospitals, a full breadth of services across the spectrum of healthcare. I'm the CFO of a number of the entities inside of MGB, including Newton-Wellesley Hospital and Mass General Brigham Home Care. Among others, and I've been in the system for about 25 years in a variety of different roles at corporate, at some of our academic medical hospitals, and now here mostly focused in the community.
Thanks for being here, Vin. And Scott, let's turn to you.
All right, thank you. My name is Scott Faude. I'm Chief Financial Officer of the Provider Division within ProMedica Health System based in Toledo, Ohio. ProMedica, we operate three major divisions: a health plan, our senior care division, and then our provider division, which is made up of our acute care hospitals and our employed physician group.
Thank each of you for being part of this conversation and for sharing your perspective as CFOs. Let's begin by discussing your different experiences of getting started and what went into building a business plan for your robotics programs. When it came to initial investments and building a strategy, who were some of your biggest partners? And then also just any valuable insights you would like to share about laying the groundwork for these programs. Vin, let me turn to you first.
Sure. I've had the great benefit of initiating a number of different robotic programs, both at academic medical centers in the community. First started about 10 years ago when I was at Brigham and Women's. We went early and sort of soon and tried to go as big as possible into the robotic space. I think what we found there was that the robot was more about having it than actually implementing a full-blown program. I had left the Brigham and went to Leahy Hospital, and there I teamed up with a robotic surgeon who with a specialty in colorectal, and he really began to educate me on the benefits of robotics and the establishment of a full program. And it's there that I first heard the term that we didn't want to be a hospital with the robot, we wanted to be a hospital with a robotic program. And he really sort of set my mind around the benefits of robotics, and we had a successful run. He ended up leaving and going to Newton-Wellesley Hospital, and coincidentally, it's where I ended up coming back after 3 years inside of the MGB system. And we set about right away doing the same thing because the market in Boston is fragmented. And we saw a real opportunity given the services that we provide, especially in the region where we reside, a very high margin opportunities with the highly commercialized population in this part of the state. And in that fragmented market, if we really push that agenda of not just being a hospital with the robot, because there's a lot of those in Boston, but a hospital with a robotic program targeted to particular audiences, and in particular in our region, we felt there was going to be an enormous opportunity. So, you know, the partnership with a lead surgeon who I trusted, and the opportunity to really build a robotics program in a geographic area that I think was really asking for it was important to help us get the program off the ground, and we're off and running here at Newton-Wellesley.
I really appreciate that distinction, Vin, about not just being a hospital with a robot, but being a hospital with a fully developed robotics program. Scott, did you see something similar when you were getting your program off the ground and developed, or what was your experience like?
Yeah, it was similar for us as well. Up until 3 or 4 years ago, I would characterize it similarly. It was we were hospitals that had robots. We really didn't have a robotic program. So about 4 years ago, we started to evaluate potential expansion and standardization of our robotics program, and I was heavily involved in that. Worked closely with our surgical services leadership team, which included both clinical folks as well as physician leaders, and similar to Vin, they helped educate me on the value and the benefits of a full robotic program. I would say probably as a financial leader, I was a little skeptical at first as to, you know, what the best decision would be for our health system, whether we should, you know, continue to just purchase the robots as we needed them versus, you know, entering some other type of financing type arrangement where we were more or less leasing robots. At the time, you know, I thought robotics was more of a loss leader, and that our margins on the robotic cases were, you know, maybe less than than how we were doing the cases. But as I was educated by our clinical and physician leadership, you know, this was something we had to look at more strategically for, you know, quality reasons, patient outcomes, patient preference, and surgeon recruitment. You know, at that point, we had to balance the cash outlay or financial investments for what we wanted to do with our robotic program and the need for more robots in order to accommodate the demand. We basically felt at the time that if we didn't do something, we were going to lose cases to our competitors. You know, so again, you know, moving in the direction of more procedures done robotically was really a mind shift change for me, again, because, you know, the margins on our non-robotic cases were healthy and good. But I would say strategically, the other reasons for moving towards a more expansive robotic program, you know, outweighed what the initial thoughts were in my mind.
Jerry, thanks, Scott. Jerry, let me turn to you to have an opportunity to react to what your co-panelists have said. And then also, if you could tell us too about the foundational elements that were required for your robotic service line. How did those lead to building site-specific plans? We'd be interested in hearing about that too.
Yeah, very similar to Vin, Scott. You know, I was very skeptical of robots, and I would use the term maybe burned before. But you know, mainly because we didn't have a programmatic approach to it. We were all fairly new into this tool. But as Vin and Scott have, you know, meeting the right doctors and providers that talk to you about what the value is and how we build programs, and actually seeing that. You know, in my current role, and we have 11 different hospitals, but beyond the hospitals, we have off-campus surgery centers, both HOPD based as well as ambulatory, in various markets that compete very differently. We, you know, some of our markets, we're in a very tight, condensed competition with in Tacoma area versus, you know, in Seattle, where it's a little bit more wild west. And the question is, if everybody had robots, how are you going to differentiate yourself from others, right? So, and bottom line is the foundation is, like most CFOs would look at it with skepticism first, and then secondly, you know, there is truth within the numbers. You know, utilization rates one way, but then what's between those numbers, what type of cases are we doing? And then looking at your strategy, where you want to be a market differentiator in? Is it in colorectal? Is it in bariatrics? Where do you want to be? Rather than just the bread and butter cases. And what we did was fundamental is having that right level of data. And then number two, understanding, and this is a little bit more subjective, understanding the right providers that have the right intent to grow the program. So with those things together, those were the fundamental pieces we had to put together as we talked about progress.
Each of you just shared a lot there, and we're going to circle back and expand on some of the points you raised. But let's start with data. So clearly, as CFOs, you're used to having a wealth of information, metrics, data points at your convenience. But I'm curious about the metrics that you have found to be really key to quantifying the success of your programs, and what data is important for you as you continue to track your robotic service lines. I'm curious about what has become really important and essential to you in these efforts. Scott, can I turn to you first to share the data points that you find yourself leaning on the most?
Sure. I guess, beginning on the financial side of things, we really are trying to focus on the overall cost of care, not just looking, at profitability of these cases necessarily in the operating room, but looking at the overall cost of care, which, would include length of stay, readmissions, costs associated with surgical site infections, those types of things. We're also looking at quality metrics as we evaluate the program, patient outcomes, and then lastly, metrics surrounding, capacity and access both in our operating rooms as well as in our, inpatient nursing units or patient care units. Generally our approach to data, is can we do more with less, and how do we do more with less? There's one of the big things we're working on that we feel robotics has helped us with, and we continue to focus on, is length of stay. We have millions of dollars tied up in length of stay, and we're constantly working to kind of crack the code, for lack of a better term, as to how we can reduce length of stay, reduce the costs associated with that length of stay, as well as increase capacity. And we believe that our robotic program has helped us with that over the years. We've seen that strategy play out. The deployment of the robots, was a key component in trying to free up capacity, both in our ORs, especially at our tertiary hospital in Toledo. It's allowed us to create access by getting cases to the right site of care. We've still got more work to do there, but one of the things we have seen is with the deployment of more robots throughout our system at the majority of our hospitals, we've been able to create some access at our tertiary facility for more surgical procedures to be done. So it's also allowed us to look at metrics in our rural hospitals that we otherwise wouldn't have looked at, and create some access and demand for procedures there, and allow patients in those communities to get the care in that community versus having to go somewhere else to have a procedure done on a robot. We're always looking at our surgeon quality metrics, and in partnership with Intuitive, we're evaluating those metrics and making sure that they meet the standards of care that we've established, and continue to strive for it at ProMedica. And then I would say, lastly, with data, we entered a data sharing and collaboration with Intuitive, and that has been a key component, not only in evaluating our current success with our robotic program, but also in driving future success.
Great. Scott, you just highlighted a number of metrics, and also how the spillover effect the program can have on various sites of care in your institution. Vin, I'm going to turn to you, and I'm curious if, when you were looking to obtain this data, if you faced any roadblocks, any challenges in getting the right amount of data and getting what you needed.
I would say on that front, since much like Scott and Jerry, we have deployed robots across our system, and we've got, say, upwards of 8, 9, 10 hospitals in the Boston area. And so there's been this a bit of internal competition, wondering who's got what and who's expanding what programs. As we followed that strategy, so it was hard to get information, fully, and until sort of Intuitive began bringing forward some of the metrics in terms of utilization and productivity, which are definitely important to us. And what we found was that it really highlighted for us at Newton-Wellesley that our productivity in this programmatic approach was significantly higher than even some of our colleague hospitals across the region. And so that was really helpful for us once we gathered just that basic data of utilization across the system and utilization across the market. As Scott mentioned too, it's not just about the profitability, but obviously that's quite important to us. So the ability to marry up our productivity and utilization data with our cost data to get at that cost per case, because as you mentioned, total medical expenditures are really important. And as we begin and continue to plan for the shift to value-based care with lots of risk, the total expenditure over the episode of care becomes critically important. And so a shorter length of stay, lower utilization and prescribing of opiates coming out of surgery, faster recovery time for the patients post-robotic, so they're back to work much faster. That begins doing all of that work now helps set us up for the future as we compete, not only regionally, but in the National Brigham system. There's a component to this of national competition, and it could set us up really well for some type of bundled payment arrangement with large employers across the country, or other types of arrangements like that. We also take the approach that the lower end cases that are done on the robot are there for learning opportunities. And it also is a way to test out those providers that actually adapt well to the robot. And some don't want to be on the robot, and that's fine. But we also know that the cost of some of those lower end procedures, we don't make much money on, but it is the training ground for them, for the surgeons to move up into higher end surgeries. And we've done some first in the world type stuff, not only in the system, but here at Newton-Wellesley as a community hospital. And we found that 90 to 95% of the robotic procedures that our system is performing can be safely done, more than safely done at the community hospital setting. So building on that, that's where we really saw this opportunity to utilize our location, better data, better metrics, and the pairing of all that together with the cost information to really make a case for expansion of the program.
And Jerry, I'm going to turn to you and circle back on something that came up from you and your co-panelists in your first responses, which is about the importance of good, healthy, and close working relationships with the clinical team. You heard Vin mention the surgeon that he trusted greatly. Scott mentioned the surgical services team he worked with closely. So Jerry, I'm curious about how you approach conversations when surgeons come to you and ask for an additional investment. How do you navigate those discussions? And then also, how do you ensure there's success for both parties involved?
Yeah, thank you for the question. And I think for all the folks listening and the CFOs on the panel here know that this is a loaded question. But a lot of what we do is both objective and subjective. And the trust part is the subjective part, knowing which providers are asking for the right stuff and with the right intent. I think everybody wants to play with the newest and coolest tool that's available in the market, but we also know it also takes the right carpenter as well to use the tools. So one of the things that we do a lot is, I tend to not get into the weeds too much, but I do lay out high-level expectations that are fairly transparent and easy to digest with our key strategic partners. So the first thing is really identify who we want to partner with, not just from obviously a vendor perspective, but as well as our surgeons. Knowing who our programmatic leaders are first, and then we set out almost a tier level expectation, not just on volume, but on quality outcomes too. Because like Vin was saying earlier, there are certain cases you have to do as training grounds, and therefore you have to start with those. But at a certain point, we want to start moving into market share growth, market penetration, and really growing some of the programs. So having a tiered level expectation with the providers on the quantitative and the qualitative outcomes is extremely important. And setting that out over a 3-year time frame is usually how I do it. And as we hit in certain tiers and hit certain triggers, then we invest more and we discuss what's the next level. But it's high level, and then we hand the reins really over back to the providers and say, we're investing in you, we trust you. Here are the high level guidelines, you make it work. And so far we have not been disappointed.
So I'm hearing, Jerry, it sounds like that tiered approach is really important. It lays out a roadmap for people so they know when they hit a certain level, there's going to be more investment, like you said. And then also it sounds like an anti-micromanagement approach as well. You really empower them to take the lead here.
Absolutely correct. And I think with that I think all the providers, everyone around that table that we bring to the table, really believe in the program. And I think allowing folks to have that reign, everyone wants to take ownership, and I think suffocating that ownership would be detrimental to the business. And I think that's just a leadership philosophy approach.
Thank you for sharing that. You know, we often hear pushback on the cost of robotics, and I think it even came up in some of your earlier remarks from the CFOs on the screen, but you are all moving in the direction of expanding your programs right now. So how has the understand that total cost of care that's come up so often already really made an impact at your institution? And have you found that a robotic service line is helping to achieve more strategic initiatives at your health systems too? Scott, can I turn to you for your initial thoughts here?
Sure. Yes, I think as we've kind of alluded to and prior in the discussion, our initial assumption with some skepticism was that, as we went into growing the robotic program, that we weren't going to make as much money on these robotic cases, but it was something that, strategically, we wanted to do for, quality reasons, patient outcome, surgeon recruitment, patient preference, and to remain competitive. At that point, as we were evaluating it, our evaluation period, we went through many iterations of this over, probably a year's time, that we had to, look beyond just kind of the transactional cost per case in the OR and analyze it and really scrutinize what we were seeing with what I'll call downstream savings as it relates to, length of stay, readmissions, surgical site infections, other quality areas that may impact financials, as well as, capacity demands and access in the OR. So again, as we were evaluating, we wanted to make sure that we took into account the overall cost of care, not just the direct costs in the OR. Our philosophy was to look beyond just what we might label as variable costs and contributions in the OR and evaluate the program as a whole. When we did take a look at the financial viability of the program, we looked at it holistically and strategically versus transactional. And, it's been very beneficial from those aspects to us. And it's, something sitting here today that I would say, I'm very happy that we expanded the program. And it has had both financial benefits as well as, quality outcomes and other benefits to the patient. So.
Then let me turn to you to see if there's anything you would add to what Scott shared. And also I'd be curious what you would say to a CFO who perhaps similar to you not that long ago thought of robotics as a loss leader. Is there anything that from your experience you would be quick to share with them?
Yeah, I think I'll reverse the order of the questions and say what I would recommend, especially, depending on what your market dynamics show, what is the status of your hospital in terms of capacity, both on the inpatient side and in the operating rooms. For us, a number 4 or 5 years ago here at Newton-Wellesley, we had inpatient capacity and we had OR capacity. And the robot was like one of the programs that either promised or was growing at double-digit growth. So it was easy for us to make the decision to expand. And so I think it all depends on sort of where you are in the marketplace, and you need to have that willingness to get over the hump of just converting existing profitable services into something that potentially could lose money if it's just those basic level services. From a strategic standpoint, more so on your first question, we have to make sure at our community hospitals that we're also supporting the strategic goals of the system that we're part of. And in that realm, our 2 major academic medical centers in downtown Boston are full to capacity. And so moving cases out to the community, moving care out to the community is an important strategic goal. And this program, the robotic program, fits perfectly right into that strategy, and it's a perfect program to move out into the community. And as I mentioned, I think previously, from a population health standpoint, we think over time this will really position us well regionally and potentially nationally to be in a great spot to help manage populations better with bundle payments and risks. And then the third thing, which I think you said in your, Molly, in your opening comments, we can't underestimate the desire of physicians, of staff, and of patients wanting this service. So part of it is just meeting the demand of society and meeting the demand of what surgeons want in their training. And so I don't think you can be a sort of modern, current sort of hospital without providing this type of access to the machines, or you're going to lose market share, and it starts a spiral that nobody would want to be on.
Mm-hmm. Let's stick on that point for a minute, Vin, because you're right. I mean, we've talked about the strategy now, but when you talk about the talent and then the people, the need for care teams and physicians that make all of this possible, let's stick on that point for a little bit and get your thoughts on this. What are you experiencing now when it comes to staffing and running your ORs, and how is robotics playing a role in attracting and training residents?
Yeah, in our case, we see that in our patient engagement surveys, the teams that are working inside the OR, particularly on the robot, have some of the highest staff engagement scores because it's new, it's energetic, it feels like it's cutting edge. Surgeons, particularly in our residency training programs, and we are a hub in the Boston area for training residents, they seek out the program that we have at Newton-Wellesley. They want to be trained at Newton-Wellesley, even though their residency may be at, nationally known Mass General and Brigham and Women's. But we've crafted the program, this hospital, with a robotic program, not just to be the provision of services in the operating room, but expanded that to be a phenomenal experience for residents, so that ideally they stay, here at Newton-Wellesley because of the growth of the program, or they move on to other parts of the country, or frankly stay within our system, and maybe not here in Newton-Wellesley. But so we're trying to tie in all of those things together as we move down this journey of robotics, and whatever that's fully going to mean in the future is still playing itself out.
Yeah, I think, robotics as a retention tool, perhaps even a few years ago, wasn't as high on the list of reasons to pursue it. But now I think, as your comments highlight, Ben, the labor market and what you're seeing, it perhaps is more so now. Scott, what are you seeing with your ORs, with staffing and attracting talent? Anything you would add to Vin's comments?
Well, I would say it's actually very similar to what Vin had mentioned. We believe our robotics program has helped advance our academic programs and our academic mission and the training of residents, which has also led to, helping us recruit young, talented surgeons. I think, as Vin mentioned, you're seeing it more and more when they're, coming out of their residency. They want to be doing as much as they can on the robots, and having the robotic program that we've developed over the last several years has helped us recruit and retain many surgeons and many young, very talented surgeons. Additionally for us, and I think, Vin touched on this a little bit in a previous answer, as it relates to our community and our critical access hospitals, it's allowed us, having robotics at those hospitals, which we previously didn't, it's allowed us to, recruit surgeons into those communities and retain those surgeons in those communities, and therefore enabled us to, create access for patients in those communities so that they can remain, in their local community, have the procedures done there, as opposed to if they, wanted a robotic procedure, leaving their community and going elsewhere.
Thank you so much, Scott. Jay, I'm going to loop back to something you had said about the tiered metrics that you laid out, and they're qualitative and quantitative. So as MultiCare is looking to strategically grow volume, can you share some insights about how you're making those investments, what you're basing those decisions on, how you communicate this vision of growing volume to the surgeons?
Yeah, quite honestly, I can have all the vision in the world, but if I don't have the providers to share that vision with me, it usually doesn't work. And I'm a fairly physician-centric, provider-centric CFO, and I think we all are. know that to be successful. One of the things is as we're looking at robotics, and as this robotics become commonplace in our industry, it's a for the what I call the bread and butter stuff, it's really increasing our efficiency. And in my seat, as we look at data, you can see very disparate data that comes out of individual hospitals that we have across our region, and it really depends on the physician composition and the type of services created. But ultimately, at the end of the day, we created a governance structure where we have high level of expectations on what we need to do from a compliance perspective, from a volume perspective and programmatic perspective. But then what we also push on our providers is to what are businesses that you are passionate about, that you're learning about, that is groundbreaking. And I think Vin talked about earlier, they're doing cases in their community hospitals that are first in the world. So we talk about that quite a bit. What are some of the work that we're doing that can really not just get more market share, because at the end of the day, in some of our markets, it's an equilibrium process, right? So everything kind of balances out. But then how can we provide care, the type of care that they're studying, they're researching, and really allow them to get really passionate around using the robots and getting more proficient at it.
Scott, is there anything you would add to Jerry's approach he outlined in terms of sharing this vision around volume with the surgeons?
We did something similar, and I'll circle back to especially post-pandemic now. One of the big issues for us is creating capacity and access. So I think as we think strategically today about where we want to head, it's all about creating that additional capacity and additional access in our OR, not only in our ORs, but again, in our kind of inpatient patient care units, expanding the robotic program for us and working with the physicians and at the time that we expanded, as well as continuing to work with them, we're continually focused on driving right side of care for these types of patients. Do they really need to be in the tertiary OR, or can we do these procedures elsewhere? We've made some strides as it relates to that, but we still have a lot of work to do there. It has helped open up some bed capacity for us on the inpatient side, as the robotic procedures have helped to reduce our length of stay, along with other initiatives. And I would say in the tertiary OR, freeing up that access and having robots at other hospitals has allowed us to kind of decant some of those procedures out of the tertiary facility, open up access for more appropriate procedures to be done in the tertiary OR.
So looking to the future, and I know at this point it's probably hesitant to do so, right? We've had a couple of times where we thought we saw what was coming down the road and turned out to be wrong, but nonetheless, let's take our chances today. If you were looking to the future, what initiatives are you really confident your system is going to remain focused on in terms of standardizing operations, expanding minimally invasive surgery options for physicians and the patients you serve? Vin, let me turn to you for your thoughts here first.
The robotic surgery gives us this opportunity to be really good on sort of standardization, as opposed to being left to the sort of individual talents and techniques of our surgeons that may be applying things a little differently on a case-to-case basis. So the utilization of the robot tends to drive standardization, especially the way we are training our surgeons in our program. We've spread it over 7 service lines now, and it's a rigorous training program. We're trying to become a national training site at Newton-Wellesley, at a community hospital, and we're well on our way to doing that. But having that sort of approach to the surgical robot is helping us in the standardization of process and the setup of our operating rooms and how we do things. So that's been really helpful. We've matched that up with physician level cost data to see who's using what supplies and what the costs are almost at a physician level. So the bringing together those two things help us really position better for the future. Minimally invasive surgery is going to be critical, as I think I maybe mentioned earlier, around population health and entering into risk contracts to help us manage that cost of care of the episode, and including being really responsible and aware of the recovery time of the patient and getting them back to work as soon as possible. And we find in our cases, as I'm sure happening nationally, patients are staying shorter durations and they're up and about and in a much faster time with much better recovery. So this push on minimally invasive surgery is only going to continue, and we need to be prepared to adapt to it and change how things are happening in the operating room. And with that, standardization of our approaches in the operating room without limiting the creativity of the surgeon. There's a balance in there somewhere. And while we won't demand full standardization, there'll be a migration continuing towards it.
And Scott, what's your outlook look like?
Yeah, I would say it's very similar to what Vin had mentioned. As we continue to look to standardize our operations and our care, we're working closely through the robotics program, as well through some co-management agreements that we have with our surgeons to standardize that care, to make sure that we're doing the right thing for the patients through that standardization, right thing for the surgeons, as well as right thing financially for our organization. We're still on that journey. We've come a long way. The expansion of the robotics program has helped us with that. We still have a ways to go, so we will continue on that journey as we move on. And I would say, again, as I mentioned before, looking into the future, the other big journey for us is the right side of care. And we still, as I mentioned, we still have quite a bit of work to do there in getting the right side of care for the procedures, getting them to the right setting, whether it's an ambulatory surgery setting, with a robot, getting the right technology there so that we can get those, what I'll say, lower level cases, out of the main hospital ORs, get them into more of an ambulatory surgery setting, which is, better for the patients as well. Gets it into a lower cost setting for us, so that I would say that journey for right side of care is something that we started, and we're still in the infancy on that, and we have a long ways to go on that one.
Well, Scott, I saw your co-panelists nodding their heads when you brought up that point, so I don't think you're alone in that effort. Panelists, thank you so much. This was just a terrific discussion. As we wind down here and get to our audience questions, is there anything I didn't ask you that you wanted to share? Any other closing thoughts you wanted to put forward?
I'll offer one. The path is not easy, and the path is not perfect. And I think even as we sit here as panelists, we are working through our systems through different opportunities and certain barriers. But I think the robotics are here to stay. I think just looking at robotics from a pure contribution margin perspective, direct contribution margin perspective, is short-sighted. I think the qualitative outcomes is going to be important, but then how we leverage it, and then how, like we talked about earlier, the side of care, how do we differentiate, larger, more acute cases like cardiothoracic, bariatrics, colorectal, oncological, versus the bread and butter stuff we said earlier, and how do we put in the right care settings as we all try to navigate now in the current environment through this pandemic, and all of us are affected by the cost structure and how we're being reimbursed. It's going to be a work in progress, and we're all learning together, but leaning on the data is going to be very important.
Thank you, Jerry, for sharing that thought. Well, Jerry, Vin, and Scott, thank you so much for that discussion. We are going to now begin today's question and answer session. So attendees, you can submit any questions you have by typing them into that Q&A box you see on your dashboard, and we're going to try and get through as many questions as we have time for today. A couple have already come in, actually, so let me turn to those while others submit their questions still. Here's the first one. Are you seeing a shift in more patients seeking minimally invasive care options in your market? And how have you leveraged robotics as a market differentiator? Also, a service line approach has been referenced during this talk. Can you provide reasoning into viewing it that way? Would any of you like to take the first swing at that question? It's a two-parter.
Sure, I don't mind going first because this is very germane to our marketplace in the western suburbs of Massachusetts, of Boston. The communities that Newton-Wellesley reside in, the towns of Newton-Wellesley, Weston, and Needham are some of the wealthiest communities east of the Mississippi. And so our patients are drawn mainly from those wealthy towns, and they have demands, they have expectations, the patients do. Frankly, they're brand shoppers. And so on the one hand, we need to be prepared to meet the demands and expectations of our patients. On the other, we're 6 miles from downtown Boston, and they can easily just pass by us. So to get downtown to a big name academic medical center where they don't actually need to have that service, which can be provided safely in the community. So there is that balance for us. Patients are definitely demanding and may not even fully understand sort of what it is, but we just need to be prepared to answer that question for them and provide the reasoning why they should stay here in the community to have that service. And so that is definitely an issue and more than an issue, it's an opportunity for us that we are definitely capitalizing on. The second part of your question, which I jotted down here, was around the service line approach and reasoning into why it's viewed that way. Things are so, as CFOs, we need to understand sort of where the costs and revenues are falling. And in our current models, which we are not perfectly set up to monitor on a service line basis, we are good at knowing what the revenue is on a particular case, but the costs of providing that service are spread over many multiple cost centers. And the ability for us to pivot into a service line model through our cost accounting systems is critical. We are changing inside of Mass General Brigham how we structure to meet both needs from a financial reporting standpoint, both the P&L historical view for our auditors, but also being really good at monitoring and reporting on service lines so that we can really begin to understand fully the allocation of our costs and the methodologies we use, making sure that those are accurate because we're going to be continuing to move into pricing related to what those results show. So service line becomes critical to us in the finance office, but also on the operations side as we bring the two together to make sure we're not getting out in front of ourselves in terms of decision making based on incomplete information.
Thank you, Vin. Scott and Jerry, anything you would add about market differentiation and then also taking the service line approach and reasoning into why you view it that way?
Yeah, as it relates to being a market differentiator, we started seeing this, 4 years ago when we started the journey of evaluating expansion and moving into more of a robotic program. We started to see it in our markets here in Northwest Ohio, Southeast Michigan. We started to see that then, and it just has continued to snowball. Patients are seeking out this type of care, and I would say if we hadn't gone down the journey and developed more of a robotics program, we would have lost cases to our competitors had we not done this. And again, as I mentioned earlier, I would say it's definitely been a market differentiator for us in more of our community critical access hospitals, so that the patients can seek out this type of care and seek it out in their community as opposed to having to drive somewhere to have those procedures done. As it relates to the service line, I would say very similar to Vin, trying to look at our cost accounting across, it has been quite the journey over the last 5 to 6 years, trying to identify costs associated with different procedures and developing our cost accounting systems. I will say where it's helped in this particular case is the collaboration between the clinical folk, our clinical operators, our surgeons, as well as finance. We have various service line meetings that are held either monthly or quarterly, where all of these groups get together and we discuss the metrics. We discuss how we can become more efficient, how we can what metrics we need to look at to improve, quality, patient satisfaction, and those types of things. So I think, from my standpoint, when we've kind of developed the service line model, bringing those different groups of people together on a regular basis to discuss how we can further develop and make the service line more efficient has been very beneficial.
And then not much to add on that, but in our markets in the Seattle Tacoma area, robots have been fairly mature and saturated in our market. So what we've been trying to do, and I alluded to earlier, was more on creating awareness for our community, especially in the Tacoma area, that tend to drive up to Seattle for more of the higher acute tertiary type cases that we could do here in Tacoma historically that we haven't been able to do. So as MultiCare has historically been a more of a community health provider rather than like University of Washington and Virginia Mason. That's more academic, highly tertiary and quaternary. So, but as our surgeons become more efficient and actually enter into more difficult cases, complex cases that they're doing with high effectiveness, our job has been turned towards marketing in various forms to get outreach involved to the community, so they don't have to travel 30 minutes to an hour to get care that they can get right across the street. And quite honestly, it's some of the best in the nation right across the street. So that's something to be proud of. And from a service line, approach, cost accounting has always been historically challenging, no matter if it's robotics or not. CFOs are smiling for that, but one of the things that we've done here at MultiCare, we've done some pretty creative acquisition models and financing models with Intuitive with robots, where we can actually almost get down to a direct contribution margin per case rate that is fairly transparent. So we know very, very straightforward what our costs are going to be per case. So we've been able to do different models with that, and that's part of our actual acquisition strategy to more rural areas or hospitals that we want to enter into higher tertiary type cases that haven't been done before. So thank you.
Thank all three of you for weighing in on that question. The next kind of falls under the idea that hindsight's 2020. So this attendee would like to know, what key performance indicators have you found to be significant that you maybe didn't account for early on in those early stages of adoption? Anything that took on more significance than you first anticipated in terms of performance indicators?
Straightforward for Newton-Wellesley was utilization. I mean, the most basic of measures. We were uncertain how fast it would take off. We have been told nationally that a national average of 80 cases per quarter, and we expect to be close to that national average. And we find that we're doing, instead of 80 per quarter, we're doing 55 per month, which is just a phenomenally higher utilization than we expected. And I think it reflects the adaptation of the robots into the culture and into the desire to use those from our surgeons, and then in addition, the growth over multiple service lines. So utilization was really much higher than we expected in terms of how fast we got to sort of full usage of the robot.
Then put utilization forward. Scott and Jerry, anything you would add?
I would add to that, when it comes to utilization, I would say, we're still on that journey in some of our hospitals where we've deployed robots. Our utilization is very good in some of our hospitals, but in others we have work to do there. And, I think our collaboration with Intuitive helps us to identify that and helps us to identify ways in which we can improve that utilization. I would say other indicators that have been significant that maybe didn't go into the initial, analysis, I've alluded to some of those before, but, I would say, and it's hard to put numbers around it, but, going back to the standardization of care, I mean, it's something you can talk about, but when we're evaluating the program, it's really hard to put numbers to that. But, I firmly believe that through standardization of care and the robotics program, that we've been able to, help lower costs associated, with these cases and working collaboratively with the surgeons.
Yeah, and for me to add on to that, as a CFO, we tend to look at the financial numbers quite a bit, and sometimes we think looking at length of stay is our reach into the clinical quality space. But part of my early adoption as a CFO, entering into a more robust robotics space, is really understanding the clinical quality outcomes that the surgeons were explaining to us. So things like blood utilization, blood usage per case, readmission, surgical site infections, comparison on different types of cases, and that level of research, being able to sit down with a provider and understanding the value of newer type of cases they want to do and the type of outcomes they want to see is just as important as the contribution margin and the length of stay, in my opinion. So, and it actually helps your providers be more engaged with you as a CFO when you are well versed in those impacts of their work in those clinical areas.
Molly, just to clarify on the stat I provided, I believe the national average is 80 per quarter on a robot, and at Newton-Wellesley we're seeing between 55 and 60 per month. In terms of that's the number of cases we're doing on a monthly basis.
That's great. Thank you, Ben, for sharing that and clarifying that. I think we've got time for one more question, and it is a great one. So let me share it with you, and then would love your responses. When measuring the downstream savings, what clinical outcomes have you analyzed to truly understand that total cost of care and potential savings generated by your robotic surgery service line? And is this information included to the board in your capital acquisition process?
For us, it is, and I would say there's probably three things that we look at. One is bed backfill. The shorter length of stay provides us, given the opportunities to backfill the beds. But from a quality and clinical outcomes, the two big ones are probably readmission rates and infection rates. And utilization of the robot, we have seen in our data that has lowered both of those. And so from a quality clinical outcomes perspective, that's just as important as the financial outcomes. And we have highlighted those stats in our requests to the board for capital when it comes to expanding the robotic program.
Yeah, I would say exactly the same for us as well. We definitely point those things out when we're taking a request to the board for be it capital acquisition or some other type of leasing arrangement. So the same metrics Vin mentioned are the metrics that we focused on when we were trying to convince the board that this is the right direction to go in growing our robotics program.
Yeah, I mentioned in the previous question those same things, but I think one of the justifications we take to the board for approval is the provider strategy. Which providers are going to do the cases on these? Do we have incoming providers that would utilize these robots? So on top of the metrics that we've mentioned, it's really about physician inventory and who's going to do these cases.
This is all the time we have for today. I want to thank Jerry, Vin, and Scott for this an excellent discussion, for sharing their valuable insights as CFOs with us today. And I also want to thank Intuitive for sponsoring today's webinar. Please don't hesitate to reach out if you have any questions, attendees. Thank you again for joining us. And we hope you have a wonderful rest of your day. And we also hope to see you at future Becker's webinars. Thank you very much.